In terms of the myopathic disorders that are covered on your outline, a 23-year-old woman presents for complaint of weakness. Symptoms are most notable when she tries to initiate movements and her hands get stuck. Her examination is notable for mild bilateral ptosis. She denies double vision. If she closes her fist for several seconds, it will take several seconds to open. She reports that other family members have a similar problem. Which of the following is the most likely diagnosis? On the examination, the patient would close their hand, it would be tight, and you would say open, and it would slowly open. And if the patient keeps repeating it, it will get a little better as time goes on. So, which is the most likely diagnosis? A diabetic third nerve palsy, Horner syndrome, myasthenia gravis, myotonic dystrophy, or Lambert-Eaton myasthenic syndrome. The patient has evidence of a grip myotonia, and this is highly consistent with myotonic dystrophy. Of the other options, the grip myotonia, the bilateral ptosis would be the giveaways to myotonic dystrophy. Diabetic third nerve palsy, Horner syndrome could cause ptosis but not weakness or grip myotonia. Myasthenia gravis and Lambert-Eaton can cause weakness but typically fluctuating weakness, not fixed weakness, and no evidence of myotonia on examination. While myotonic dystrophy may feel esoteric, it is listed in your outline and is actually one of the most common muscular dystrophies. It is characterized by grip and reflex myotonia. If you strike the thenar eminence with a reflex hammer, the thumb will pop up and will stay there for usually several seconds before slowly coming back down. Strike it again, it will come up slowly. It's unusual for a myopathy in that it causes distal weakness. Most myopathies cause proximal weakness of the shoulder girdle and hip girdle. Myotonic dystrophy, the weakness is in the finger grip. There are multiple other characteristic features. Patients usually have mild ptosis. They have early cataracts, and they'll have a family history of many people having cataracts before the age of 50. There's oftentimes frontal balding with temporal muscle wasting, leading to sort of a thin and narrowed face, sometimes referred to as a hatchet face. Cardiac conduction abnormalities are common, and screening for them is important. This is an autosomal dominant CAG repeat disorder, so there's oftentimes a strong family history. If you make the diagnosis in one person, the other family members will appear with similar features. In terms of diagnosis, EMG, besides clinical history, EMG is highly characteristic. On EMG, there will be runs of myotonia. Whoever performs the EMG should be able to pick those up, usually very easily, and should note that in their report. Genetic studies can confirm the diagnosis and can be used for counseling the patient and family. In terms of treatment, there's no specific treatment that will reverse the disease. Patients oftentimes report of significant muscle stiffness and tightness, and mexiletine can be used as a symptomatic medication. What is important is these patients do need to be referred for cardiac screening. Many patients have cardiac conduction abnormalities and may need a pacemaker to be placed. Patients oftentimes have multiple endocrine disorders, so referral to an endocrinologist to look at evidence of diabetes, thyroid dysfunction, or other hormonal disorders should be performed. A 73-year-old female presents for progressive painful weakness. Examination is notable for a rash involving the face, upper chest, and hands, along with proximal muscle weakness. Creatine kinase is markedly elevated. Which of the following findings is most likely on biopsy? Perifascicular atrophy with CD4 predominance, endomesial inflammation with CD8 predominance, inclusion bodies with rim vacuoles, ragged red fibers, or lack of lymphocytic endomesial inflammation. A patient with typical myopathic features of proximal weakness, but also with a rash. So this is a patient with dermatomyositis. For whatever reason, this is a common pathology question at all levels of testing. And for dermatomyositis, the findings on biopsy are perifascicular atrophy with a CD4 predominance. Again, this patient has features highly consistent with dermatomyositis. The other answer is CD8 predominance is seen in polymyositis, which is not associated with a skin rash and is not painful. Inclusion bodies are seen in inclusion body myositis, which is an ALS-like presentation with severe muscle loss and atrophy. Ragged red fibers are seen in mitochondrial disorders, which have multifocal presentations but not skin rashes. And lack of lymphocytic endomesial inflammation can be seen in necrotizing myopathies, which also would not be associated with a rash. It is my experience that dermatomyositis and polymyositis are commonly asked on tests, and for whatever reason, the pathology for these is commonly asked. So, this is a chart that I have that I use to try to remember this, because as a neurologist I get this test question, our medical students get this test question, our residents get this test question. and I expect it to be on many tests. What I try to remember to differentiate dermatomyositis from polymyositis. Dermatomyositis is usually a painful proximal weakness, often with an underlying malignancy. Patients have perifascicular atrophy with perivascular and paramesial inflammatory cells and a CD4 predominance. What I try to remember is that dermatomyositis, D is the fourth letter of the alphabet, as in CD4. 4 starts with the letter F, like perifascicular. I just remember dermatomyositis, D is the fourth letter of the alphabet, CD4, perifascicular. And that's how I can remember it. And I know polymyositis is the other one. So it's CD8, usually painless, viral prodrome, not an associated malignancy, endomesial inflammation and CD8 predominance. What I try to remember is the D's and the F's line up for dermatomyositis. Polymyositis is the other one.